Good afternoon. So I will just present a few cases that we did here in Rambam recently, just to show how you can use everything you learned today and combine that into clinical practice. So the first case is a patient with congenital pseudoarthrosis of the tibia, and this is his clinical picture and the x-rays. What you can see on the x-ray is that it's a hypertrophic pseudoarthrosis, which is a... Marie, what you would do? Sorry? He's two, yeah.
Yes. Brace? For how long? But look at the deformity. He's walking, but it's difficult.
Okay. So when you look at the X-ray, you can see that the pseudoarthrosis is hypertrophic, which is a unique type of pseudoarthrosis because it was originally classified as type 3 in the original Pele classification, and it was omitted in the newer classification. But what's unique about this pseudoarthrosis is it can create bone, so it can build bone. So which means that the pseudoarthrosis itself can function as an osteotomy. So let's analyze the deformity. There is a small distal deformity, but the main deformity, obviously, the main apex of deformity is the pseudoarthrosis, so that is easy. The second question, when we apply the frame and going to correct that, what we are going to do with the ankle. Because usually when we do lengthening, we fix the ankle mortise with a wire or a screw, and just to keep and do osteotomy of the fibula. So the question is, what do we do here with this ankle? And the answer here is very, very controversial. And actually, Professor Edelman asked many of his mentors and friends, and the answers he got were between the ankle mortise is a bit wide, the tibia is a bit short, so just fix the tibia and start lengthening the tibia without touching the fibula, and up to an option of fix the ankle, it's stable now, whatever you do, you can make it worse. So from the beginning, do fixation of the fibula and osteotomy. So eventually what we did was do something in the middle. And the best way is not to decide what to do. So the first operation is to place a frame and using the pseudoarthrosis as the apex of deformity and start lengthening and deformity correction. The fibula was not part of the frame. And then after 1 week, second surgery. The distal wire was replaced, and the new wire was actually fixing the fibula and the tibia, and fibula and an osteotomy was done. And you can actually see that the ankle mortise now looks a little bit better than it was looking before, so it worked. And then now this is the last x-ray. He was in the clinic just a couple of days ago. And you can see that his tibia is almost perfectly straight, and he's almost ready to have the exchange from the frame to an intermedullary device like a slim rod or something like that. So that's the plan with him, and you can see that Professor Edelman is very happy with the result. So the second case is a 6-year-old boy. He had right tibial hemimelia after an amputation that was done when he was a child. And this is his deformity. So if you notice, the stump is very deformed. He couldn't actually get any prosthetic fitting to this to the stump because of the deformity. And also, if you notice where his knee is, his knee is very externally rotated. So, and this is his rotational profile. He has a very severe femoral retroversion. So and these are the X-rays. And again, let's analyze the deformity. The pictures on the right are from the multiplier app, which we use on all our 4 cases. So we have double level deformity. The first one, the proximal one, is at the level of the growth plate, and the second one is in the middle of the stump. And on the lateral X-ray, the deformity is only at the stump. So there is no proximal deformity at the lateral X-ray, which makes our life easier. And so what we did was femoral derotation of our nail to correct the femoral retroversion, close and wedge tibial osteotomy, acute correction, fixation with a plate, and medial hemiepiphysiodesis to correct the coronal proximal deformity. And this is the X-rays after the surgery. He is in a cast. After 10 months, you can see a very nice correction and nice alignment. But after a year, if we look at the joint lines and measure the angles, the MPTA is still normal, but he starts to develop a valgus of the knee, of the distal femur. So the LDFA is below normal range. So he had his tibial plate removed and femoral plate placed. These cases sometimes need just go forth and back with the plates until they get to maturity. So tibial 8 plate was removed, femoral 8 plate was placed, and then again femoral correction achieved, femoral plate removed. 3 years later, again tibial valgus, another 8 plate, and this is him today, just a week ago. He has a very nice stump and quite straight leg. The last case, 12. The last case, it was supposed to be a post-traumatic deformity lecture, so I obviously have to show at least one post-traumatic case. 13 years old girl, 3 years after fracture of the distal tibia, Salter Harris 4 fracture, had a medial growth arrest of her distal tibia and developed a varus ankle deformity. And you can see on the left her long leg X-ray, and if you measure the angles, the LDFA is 105, which is way, way beyond normal. And we're doing an acute correction with just straight medial incision, medial approach, open wedge osteotomy, fibula is osteotomy of the fibula that is done through a different incision from the lateral side, and then tricortical bone graft and fix it with just a regular trauma plate. So you can see on the left the original X-ray, and on the right is the final result after union, which provides a nice correction of the ankle. Thank you. It's not a coffee time, it's changed a bit.